All right, welcome. My name's Steve. I'm your instructor for the next hour. That's the bad news. The worst news is injector here is not working. Drug it all the way out here from Ohio for nothing. It's just that the display is not talking to the head, and I'm pretty sure it's a 15-volt power supply in the power box has gone bad. So there's nothing I can do about that. Now, so I'm gonna have to teach you everything with nothing but the sound of my voice. We'll still use, there'll be some demonstration purposes for the head here in a little bit. But yeah, so I'm Steve Maull. I'm the owner of Maull Biomedical Training. We teach contrast injectors. That's all we do. Teach you guys how to operate, maintain, and repair contrast injectors. And we'll go over that now. So there's just 5 of you, so we can do it real quick. Go around the room, introduce yourself, more biomed or imaging. Do you know anything about contrast injectors at all? We'll start over here. Any knowledge of contrast injectors are yet?
Other than, turning them on and selling to you guys, no.
Okay. Oh, okay. Yep. ZRT. That's right. It is. Yep. All right. You Navy guys, military, Navy BMETs?
Yes.
Okay. Of course. You said you're active duty. That was a dumb question. So, San Antonio, right? Was the schoolhouse?
Yes.
Yeah. I was, my starting to BMET, I was a BMET in the military, Air Force for 11 years. And that's how I became a BMET instructor. I was actually a DOD BMET instructor when we were still at Shepherd Air Force Base. And I got out in 2001. Yeah. All right. So, and like I said, my injector is down. Power supply is bad. So paid $1,000 to have it shipped out here for, I could have just brought this. Now, some of your imaging, some of your biomed, some of you know a little bit of both. So before we get to the contrast injectors, I want to go over something kind of basic about imaging. All right. So I want to go over what makes a good image on a good X-ray image. Okay. So let's say this is my X-ray table. Right. On the X-ray table, we have an X-ray tube above the patient, and then either inside the table or underneath the table, there's some image capturing device. It used to be film, then it was CR plates, and now it's DR plates. So how this works, all right, think of a normal chest X-ray, all right, where the bones, you can see all the ribs and the spine is all white, and then the background is black and everything. Okay, so you have the patient on the table, radiation comes out of the X-ray tube and goes into the patient. Now, all the radiation that comes out of the X-ray tube goes into the patient. That's not 100% true, but for my little demonstration purposes here, let's just pretend that's true. All the radiation coming out of the tube goes into the patient. Now, some of the radiation that goes into the patient is going to get absorbed by the patient and not pass through the patient and strike that image capturing plate. Some of the radiation will go into the patient and pass completely through the patient and strike the imaging plate. Okay, so that's some of the radiation gets absorbed and some of the radiation penetrates. Now, to get an X-ray image, you need both. You need both, because what happens is when the X-rays penetrate the patient and hit that plate, the areas of the plate that get struck by radiation start to turn dark. And the more radiation that strikes those areas of the plate, the darker those areas become. So think about that chest X-ray, the background is black. That black part of the X-ray image, that's the part of the film that got struck by radiation, all right? That image starts off as that plate starts off as a clear blank image, right? If no radiation struck it, the whole thing would just be white, okay? So the parts of the plate that didn't get struck by radiation were the parts that were shielded by the bone, right? The ribs and the spine and things like that. So the radiation that goes into a patient, all right, some of it penetrates, some of it gets absorbed. The odds that an X-ray photon, each X-ray particle, the odds that an X-ray photon gets absorbed by the patient is determined by the body parts, the thickness and the density of the body part that X-ray photon comes in contact with. So bone is thicker and denser than soft tissue. So bone is more likely to absorb an X-ray photon, not allow it to pass through it, than the soft tissue around the bone, okay? So that's why on the image, where the bones are on the image, well, those bones, they absorb the radiation. So those parts of the image underneath the bones, underneath the ribs and the spine, didn't get struck with radiation, so those parts of the part of the plate stayed white, whereas the rest of it, the soft tissue, X-ray went right through the soft tissue, struck the plate, turned those dark. All right, everybody follow that? All right, so that's how you get a good image, all right? And the difference in contrast is how bright is the bright parts of the image and how dark is the dark parts. The higher the brightness, the bigger the difference between the light and the dark parts, that's an increase in the image contrast, okay? So there's a reason these are called contrast injectors. Now, blood vessels which are neither thick nor dense, do not typically show up on X-ray images, all right? Which most of the time, that's fine. Most of the time when we're taking X-rays, we don't care about the blood vessels. We're looking to see if this bone's broken or separated or something like that, all right? But sometimes we do want to see the blood vessels. But again, blood vessels aren't very good at absorbing radiation. Goes right through it, just gets blacked out on the image. So what we have to do is we have to put something in the blood vessel during the actual X-ray image to make those blood vessels, those arteries and veins, absorb the radiation so they show up as lighter areas on the X-ray image. And that's what these things do, all right? That's why this is called a contrast injector. It's going to inject a contrast fluid into the blood vessels during the imaging procedure so that they absorb the radiation and produce an image where you can actually see the blood vessels on the X-ray, on the image, all right? Any questions? That's sort of basic, real quick. This is how an X-ray image is produced. All right, perfect. So on to, now that everybody is familiar with it, you can follow along in the book. The book follows the presentation here. So what I just described to you, that process of producing an image, that's referred to as angiography. Angio is blood, ography is the viewing of something. So angiography is the viewing of blood vessels. And here you can see, where's my highlighter? You can see here it's produced, it's a procedure performed to view blood vessels by injecting them with a radiopaque dye. That's the fluid that is going to be in these syringes here. That outlines them on the X-ray image. And here, what I was just describing a minute ago, where it's a black background and you know the blood and the bones and blood vessels are light. This is not my best choice of an image here because this is the same exact thing, but this isn't a radiographic image; it's a fluoroscopic image. Same concept. It's just instead of it's reversed. The background is white. The blood vessels are black. Or the blood vessels are dark, but it's the same thing. Same concept. All right. Now, when it comes to contrast injectors, in the world, there's probably 16 or 17 different models of contrast injectors that are used out there. Maull Biomedical, we teach 12 of them, okay? But all of them, all models can be broken up into one of three different kinds. There's three kinds of contrast injectors. There's CT, there's MRI, and there's angio. So there are, for the CT room, there are contrast injectors made specifically for the CT procedure, and that's what this one is. It's called the Stellan. For the MRI imaging system, same thing. There's models specific, there's specific models made to be an MRI injector. And then the third kind, angio injectors, those are your cath labs, your special procedures, your IR rooms, things like that, where it's not an MRI system, it's not a CT system, it's more your normal X-ray system that people think of, an X-ray tube, patient on the table, that sort of thing. Those are called angiographic procedures, and those are angiographic contrast injectors. Now, I always tell my students during class that contrast injectors, they're like defibrillators and infusion pumps in the sense that you've seen one, you've seen them all. They all do the same thing the same way. If you know one, you know them all. And that's mostly true with contrast injectors, all right? You know one, you kind of know all. You could walk, after my students get trained on 3 or 4 contrast injectors, they could walk up to any contrast injector on the planet and know how to operate it, know what it's doing, know how it's supposed to work and things like that. But there is a reason why there are CT specific injectors and MRI specific injectors and angio specific injectors. Each one, the 3 different types do have a little bell or whistle or feature that's kind of unique to that one kind of modality that makes it special, makes it more unique for CT images, more unique for MRI images, things like that. All right. Each of the systems uses the injector to inject fluid into the patient to improve, or in some cases, making it all possible to view the blood vessels. This is actually an image of, this is a kidney image. The images produced by this method are called angiograms or angiographs. Now, I'm gonna lower this. It sounds really loud. It sounds a little better. Yep. Now, so what we're gonna do, we have the syringes filled with fluid, all right, and then we have to get that fluid into the patient. So for CT and MRI injectors, this is universally true. CT and MRI injectors, they use an IV needle. IV needle, you go here or here, something like that, all right? For angio injectors, they don't use an IV needle. They use a catheter. And a catheter is a very long, very skinny tube that they will snake into the patient's femoral artery or femoral vein or brachial artery or brachial vein. They'll either go in here or they'll go in here. Whether they're looking at the right side of the heart or the left side of the heart, that would determine if they go into an artery or a vein. But Same exact concept, but we're just going to insert this catheter and guide that catheter to a specific body part. It'll be in the blood vessel, but to a kidney or the liver or the heart or something like that. And then they'll inject the fluid deep inside the patient, not just at the elbow or at the wrist. All right. Either way, it's the same exact effect. It's just the different kinds of contrast injectors just deliver the fluid in a different way to the patient. The contrast just eliminates itself through the body's natural waste processes through the liver and the kidneys. Now, for manufacturing, oh, I thought I fixed that. When it comes to manufacturers here in the United States, there's 3 big dogs in the fight, and there is an absolute pecking order among the 3. There's not like 2 duking it out for the top spot. Number 1, by a long shot, is Biomedical. They are the biggest probably 80% of all contrast injectors are Biomedical contrast injectors, and that's worldwide. So their main 3 kinds of contrast injectors, the Mark 7 of the Provost are angio injectors, the Stellant, and there's actually, I gotta update this again. This is the Stellant. There is actually an updated version of this. This is called the Stellant D. There is a new one called a Stellant Flex. It's nearly identical. It looks sharper. It's pretty much the same, but it's just updated a little bit fancier. This came out in like 1999. The Stellant Flex came out like 3 years ago, something like that. What's that? The D's? Yes, I think they just recently sent the end of life letter out, or the EOL out recently within the last year. Yeah. Luckily though, I mean it's basically the same as the Stellant D. The PM kits are almost exactly the same. Operation wise, maintenance wise, it's all the same. So that's the Stellant. And then for Bayer's MRI injectors, the Spectra Solaris was for 20 years the most common MRI injector. And then about 3 years ago, maybe a little bit longer than that, they came out with their newest version of it. It's called the MR Experience. So they just have a newer version of it. So like I said, they are way ahead of all the other manufacturers as far as market share, right? Distant second, but in second place all by themselves is Tyco, Covidien, Mallinckrodt, Liebel, Florsheim. I'm not even sure. Actually, no, that is, I think they also got bought out. I think they're owned by a company called Guerbet now, Guerbet, French company. Anyway, they are way behind, but they are in second place all by themselves. Their OptiVantage, their Angiomat Illumina, and their OptiStar LE and Elites. Those are their 3 most common CT injector, or most common contrast injectors out there. Way down in third place, but they do have a presence here in the United States. Bracco EZM, just another manufacturer. They don't. Anybody here with Bracco? Anybody work for those guys? Okay, they don't work and play well with others at all. They don't help you at all. They have nice injectors. The ACE CVI, it's weird. Their angio injector, it's a weird injector, but it works fine. There's nothing wrong with it. It's just dramatically different from other injectors. And then there are Empower injectors. They have an Empower CT injector and an Empower MRI injector. Really, really nice. They're great. Don't go down much, but Bracco, you call them up. If you don't have a service contract with them, they are not interested. They won't sell you anything. They won't send anybody to you. Literally anything goes wrong. Anything goes wrong with it, they make you box the whole thing up and ship it off to them. So, which, you know, they will fix it for you, but they don't make it easy for you. Luckily, there are a couple companies out there, third-party companies that do kind of specialize in Bracco injectors. They're really good. One of the best one is a company called Biomedical out of Texas. They have a bunch of guys that were factory trained, OEM trained guys, so they're really, really knowledgeable in the Bracco injectors. And they do have parts and they do sell parts, but yeah, nothing wrong with the Bracco injectors. Just the company just goes out of their way to not be helpful. I mean, if I were the ugliest girl at the dance, would you turn down anybody who asked you to dance? Seriously. All right. There we go. So the intravenous contrast highlights the blood vessels and enhances the structure of the organs. You can see here, this is actually an image of the heart. And you can see the dark background here. That's actually the heart. And the heart is about the size of your fist. And it's almost blacked out. So the radiation passed through that heart almost completely. So you can barely make it out in the background. But then this bit right here, the aorta, that's the largest artery coming away from the heart, it's very bright and shiny, and it's only about the size and thickness of your thumb. So at this particular moment when this image was taken, the heart was mostly filled with blood because you can barely make it out, but the artery here, the aorta here, is completely filled with contrast, and that's why the image shows up so nice and bright. It's very, very effective fluid. Once the contrast is injected in the bloodstream, it circulates throughout the body. So that's something that you don't have to worry about as the BMET, but just as an FYI. When they're doing this procedure, all right, the patient's alive, they're on the table, they're awake for these procedures. So, and this is, again, this is always for viewing the blood vessels. We're taking images of the blood vessels. We have to get that image of that blood vessel while the contrast is in it. So if I inject contrast into the patient's blood vessel, this blood vessel right here, all right, that blood vessel will be filled with contrast for about 1 second, because as soon as the heart beats, boom, it moves. Heart beats again, moves again. All right, it's a moving target. So there is some coordination between the imaging system and the contrast injector. It's no big deal. They know how to do it. They're pretty good at it. But it's not just a matter of filling the heart up with contrast and like, all right, hold your breath. There's a lot more timing and coordination that goes into it than that. So, and I kind of explained this earlier. There we go. The X-ray beam passing through the patient in the case of CT and angio, or the RF energy released from the patient in the case of MRI, is diminished, thereby making those areas lighter areas on the X-ray image. The anatomical structures are enhanced by this process and show up as lighter areas, like I mentioned. For X-ray and CT, now remember, there's 3 kinds of contrast injectors: X-ray, CT, and MRI. So MRI is different from the other 2. MRI stands for magnetic resonance imaging, and the images produced by an MRI system are not produced with an X-ray tube and radiation. It's produced by a very powerful magnetic field and RF pulses and detectors. Detectors that detect RF pulses emanating echoing back from the patient during this procedure. So whereas X-ray and CT injectors use an X-ray tube, radiation passes through the patient, strikes detectors on the other side, like we described earlier. So for X-ray and CT, the 2 types that use the same technology, the fluid in this syringe that makes these images happen is it's clear. It looks like water, but it's not. It's clear, but it's an iodine-based fluid. All right. The secret ingredient in a contrast for CT and X-ray injectors is iodine. The reason for that is iodine, and it's because of the atomic structure of iodine. How many electrons are in the orbital shells around the nucleus of an iodine atom? Iodine is very good at blocking X-rays. Iodine doesn't let X-rays pass through it. All right, for lack of a even more detailed description. Okay, so but for MRI injectors, MRI uses, like I said, that magnetic field and RF pulses to produce the image. Iodine has absolutely no effect on RF pulses or magnetic field. So the fluid they use is called gadolinium. Same exact effect, does the same exact effect. What gadolinium does is, without going into detail, when we fire RF pulses into the patient, the body basically echoes those RF pulses back, and the coils that wrap around the patient, I said detectors, they're called coils, that's it. The coils that are wrapped around the patient's knee for a knee MRI or head for the skull MRI, those coils detect those RF pulses echoing back from the patient. The stronger the pulse, the darker the image. The weaker the pulse, the weaker the image. So the fluid, the contrast fluid in an MRI injector looks exactly the same as the other kind of fluid. It's just the main ingredient for MRI injectors is gadolinium. And without going into any detail at all, you're just gonna have to hit the, I believe you, Steve, button. And trust me that gadolinium reduces the RF pulse energy, making MRI images look lighter. So this is a CT image skull, just another example of how effective it is. And then for MRI, gadolinium is used as a contrast. And this is I believe this is a runoff. And I actually, yeah, I was gonna say, I think my image is upside down, but we're good. Any questions so far? If you have, while I'm going through this, you have a question, let me know. Did you scan your badge to get credit for the class? Yep. You can do it now or at the end. Yep, that's fine. Just don't want you to forget. All right. All right, so I'm going to talk about something. This is where it would be nice if I had my display. For those of you who came in late, I brought my injector. My power supply's bad, and I don't bring spares. I bring spares when I'm doing class, but I don't bring spares when I'm doing this. Now, I should know better, but yeah. So my contrast injector is inoperative because of a 15-volt bad 15-volt power supply. So, but right now it would be nice if I had this. Pressure limiting. So to go into a little bit of explanation, all right? We're all who's the last two? Are you BMAT or, okay. So whenever we're doing an injection into a patient, okay, there's three things that the operator has to program into the injection. They have to program in flow rate, okay, volume, and pressure limit. Okay, now flow rate is how fast are we going to inject this fluid into the patient. It's always in milliliters per second. The typical injection is 3 to 5, 6, 7 milliliters per second. All right. The other thing they have to program is volume. How much fluid? Not how fast, but how much fluid are we going to inject in the patient? 40 milliliters, 60 milliliters, 120 milliliters. All right. So those are the two main ones. And then the third thing, needs a little bit more explanation, is something called pressure limiting. Every contrast injector, with one exception, every contrast injector, the operator has to select pressure limit. And what the pressure limit is it's the operator telling the injector, do not exceed this pressure, and it's typically in PSI. 99.9% of the time it's PSI. Don't exceed this pressure in the syringe. All right, and that's the important part. Don't exceed this pressure in the syringe during the actual injection. Now, a typical pressure limit for CT and MRI injectors is 300 PSI. That's basically the max. Some injectors go to 325 PSI, but in general terms, 300 PSI is the maximum pressure limit that we will allow to build up in the syringe during the actual injection. Now keep this in mind though, and this is a confusing part for some operators. That 300 PSI, one, is not a goal, okay? Like if I select a flow rate of 10 and a volume of 20, yes, when we do the injection, I want the flow rate to be 10 milliliters per second, and I want the injection volume to be exactly 20 milliliters, and then it ends, all right? But if I select a pressure limit of 300 PSI, all we're saying is don't exceed 300 PSI. If during the injection we only get up to 20 PSI, that's fine, all right? We're just saying don't go over this, okay? And another thing, important thing, that 300 PSI is in the syringe, all right? That is not in the patient. Anybody work with infusion pumps? Mess around with infusion pumps? All right, what's the occlusion, what's the alarm occlusion pressure on a typical infusion pump? It's like 12 PSI, right? Somewhere in that range. So, I mean, in an infusion pump, if the system senses that the pressure limit has gotten over 10 PSI, it shuts the system down, or it doesn't shut it down. It stops the infusion, alarms go off, nurse comes over, fixes whatever the issue is, and fires it back up, all right? So no, we're not gonna fire 300 PSI into a patient. Plus 300 PSI in a patient's heart, and actually, that 300 PSI, that's CT and MRI injectors. Angio injectors, the one where they use a catheter, that can get over 1,000 PSI, 1,000 or 1,200 PSI in some cases. No, of course we're not putting that in the patient. So how this works, and you have to kind of know your fluid dynamics a little bit. 300 PSI in my syringe here, when it gets up to this 1 millimeter wide opening here at the top and goes into the connector tubing, which I'll show here in a second. Now we're down in like the single digits of pressure limit, or the single digits of pressure. There's 300 PSI here. There's literally, doing this slightly wrong. There is literally like 3 PSI when it gets in here, okay? And it goes to the IV needle in the patient. So that pressure limit, and again, that pressure limit is not a goal, okay? So what the pressure limit is designed for is so my syringe doesn't rupture during the actual injection. It is a patient safety thing, but it's not really for the patient, it's for the syringe. We're saying don't exceed 300 PSI because that will keep the syringe, hopefully, from rupturing during the actual injection. And they're rated at 400 PSI. And another thing too, I don't think I mentioned it, syringes are one-time use only, like all syringes here. They use it on one patient and then they throw it away. There's a couple exceptions to that, but they're kind of special cases. So, I mean, it's not like the syringe is going to get old and eventually wear out. Now that does for us as BMEDs, because when we're working on contrast injectors, you'll get a syringe, you don't throw the syringe away after each injection. That's your PM syringe now. You're going to use it dozens and dozens of times for PMs. But eventually, someday, it will probably rupture when you're doing a pressure check. And it's just the nature, it's just how it happens. When it happens, it'll happen while you're doing a PM in the room in the hospital. So you literally can turn around, say, "Can I have another syringe, please?" and carry on. All right, so that's what pressure limiting is. Now, the one factor that determines 99% of how much pressure is going to get built up in the syringe is the flow rate. The faster the injection, the greater the pressure in the syringe. All right, so this is a 200 milliliter syringe. All right, and let's say, let's say 200 milliliters. Let's say I set up an injection for 1 milliliter per second for 200 seconds. All right, so that means it would take, what is that, 3 minutes and 20 seconds to shove all the fluid very, very slowly out of this syringe through this little tube here. All right, I mean, that's almost no pressure at all getting built up inside the syringe. All right, now let's go to the extreme. You can't do this, but just as an example, let's say I can select a 200 milliliter per second injection. For CT and MRI, I'm going to mention this later, but I'll bring it up now. For CT and MRI, maximum flow rate is 10 milliliters per second. All right, that's why they only go up to 300 psi in this range for pressures. For angio injectors, they'll go up to, depending on the model, they'll go up to 40 or 50 milliliters per second. It's just due to the nature of the beast and how they're using it. Angio injectors just need to inject fluid much faster than CT or MRI injectors. So, so at worst case scenario, it's 50 milliliters per second. But let's say we had an injector that could do 200 milliliters per second. That means we're going to shove all this fluid out of this little tiny hole here in 1 second. That would be a monstrous amount of pressure built up inside this syringe. The only reason I'm bringing it up is so everybody can imagine that sort of scenario. All right, the faster the injection, the more pressure that gets built up inside this syringe. All right. It protects, so this is what I was talking about earlier. Pressure limiting protects the syringe from rupturing during the actual injection. It does this by reducing the flow rate. Now, like infusion pumps that I mentioned earlier, when an infusion pump hits its pressure inflection, it literally stops the infusing. All right, stops injecting. Now, for angio or for CT and contrast injectors, if for whatever reason during our injection the system hits its pressure limit, say we're doing a CT injection and it hits 300 psi, right? It does not stop the injection. All right, we don't want to stop the injection in the middle of this procedure. The reason for that is, all right, other than this fluid right now during this imaging procedure, what else are we firing into the patient? What room are we in? Yeah, we're shooting x-rays into the patient, all right? So if we stop the injection, that means all the radiation dose we just gave the patient was for naught. We're gonna have to do this over, and that's more patient dose, okay? So if the injector doesn't stop the injection when we hit pressure limit, what does it do to keep the syringe from over pressurizing and possibly bursting? It just slows the injection down, okay? There will also be an audible tone when the injector hits the pressure limit. There'll be a beep that lets the operators know, hey, we just hit the pressure limit on our injection. So when you hit the pressure limit, it just backs off on the flow rate, okay? Now the reason it does that, let's say we're shooting a flow rate of 5 milliliters per second, and for whatever reason it hit our pressure limit. So the system doesn't stop, but it'll slow down just enough to keep the pressure just below maximum during the actual injection. So we don't exceed 300 psi, we'll just keep it a little bit below 300 psi. Now that might just require us to go from a flow rate of 5 milliliters per second to 4.8, all right? We'll still get an image. The image will still work, all right? If it doesn't, then we're just have to shoot the patient again, figure out what the issue is and shoot the patient again. But if the injector stops, yeah, we're definitely gonna have to do it over again. So that's why for contrast injectors, if the system does hit its maximum pressure limit, it doesn't stop the injection, it just backs off on the flow rate. And then they'll assess if they need to reshoot again afterwards. But to be honest, hitting the pressure limit it's a very rare thing. More times than not, it's some sort of, I don't want to say operator error, but that's the best way to describe it. It's some sort of error that the technicians or the doctors or nurses have made during the actual injection that caused the pressure limit. I mean, if the protocols are set up the way they're supposed to be set up and we're using the right size tubing and the right size needles and the right size catheters, it should shoot just fine. If there is a pressure limiting, there's something's gone wrong that is usually relatively simple to correct. All right, any questions? Okay. Now, this is what I was talking about earlier, things that affect the pressure, and I mentioned the first one, the selective flow rate, by far. I mean, almost all of it is on the flow rate. The higher the flow rate, the higher the pressure. But there are two other things that also affect the pressure, a small amount. The first one is the length and the diameter of the connector tubing. So we have the connector tubing attached to my syringe here that goes to the patient. The longer this tube is, the greater it's going to increase the pressure a little bit. Then the skinnier, think about it, the thinner this tube is, the greater pressure that it's going to be. All right. And then the other thing is the viscosity, the thickness of the contrast fluid. Now I said it's clear. Contrast fluid is clear. It looks like water. And if you ever like see it in a cup or on a table, it appears to be water. All right. It's very, very thin. It's almost as thin as water, but there is a slight syrupy texture to it. Very slight syrupy texture to it. So, I mean, if you're running it through, you know, a tube this size, you couldn't tell the difference between water and contrast. But if you're running it through an 18 gauge, I'm not 18 gauge, 26 or 28 gauge IV needle, yeah, then if you have a slight amount of thickness to the fluid and then you're trying to shove it through that small of a needle, yeah, that will affect the pressure as well. So what they do for that is this right here. This is a heater, all right? Now what it does, it's called a syringe heater. It's a little bit of a misnomer. It should be called a syringe warmer because it doesn't heat contrast up. What they'll do is they have their bottles of contrast, and it's typically glass bottles. They'll keep the bottles of water, keep the bottles of contrast in a warmer. They'll keep it at 37 degrees Celsius, body temperature, 98 degrees Fahrenheit. They'll keep it warm. Then they'll fill the syringe up, and then they'll put the warmer on it just to help the system keep the syringe at 37 degrees Celsius longer than if we just let it sitting here for 20 minutes at room temperature. So it doesn't, but it wouldn't, I mean, it's not strong enough that if I put, you know, what is it, 70 degrees in here? If you put 70-degree contrast in here, this would not heat it up to 98 degrees. It wouldn't be helpful at all. So contrast, if they want it warm, they have to keep it warm in a warmer. All right. But yeah, so and the thing about syrup, all right, pancake syrup, you know, cold syrup runs real slow. You heat syrup up, makes it runnier. Same exact concept, same exact concept. It's a small effect. It is a very small effect on pressure, but they do everything they can. They do everything they can to keep the pressure as low as possible. All right. Now for contrast injectors, and this is universally true. All right. All makes, all models of contrast injectors have the same three components. None of them have two, none of them have four, they all have three. And that's the injector head, which is where the syringes go, the display, where the operators enter the protocol, enter the shot that they want to shoot, and then some power supply, okay? Some injectors, when you're talking about doing the PM, typically a PM for a contrast injector, depending on the model, can be anywhere from, I mean, a full PM doing everything the way you're supposed to do it, anywhere from 45 minutes to an hour. All right, there's a lot of cleaning that takes place when you're doing contrast injectors. But a typical PM, 45 minutes to an hour. There's one injector model, and that's called the Provis. It's still very common. It is end of life, but there's still tens of thousands of them out there. That one takes about 2 hours because it's older system and it just has tons of things to do to it. Whereas newer kinds of contrast injectors, you just don't do any of those things. So the one exception is Provis injector will take an hour and a half, 2 hours, depending on how experienced you are and how much cleaning is necessary. But for the most part, it's an hour or so. Okay. But having said that, make, model, manufacturer, it doesn't matter. Every single contrast injector out there is just made up of the three components: the injector head, the display, and the power supply. Now the syringes, this is also almost universally true. There's two exceptions, but for the most part, the syringes here, they are model specific. This right here is a Stellant syringe. This only fits on Stellants. As a matter of fact, I can add this to my presentation now. It doesn't even fit on all Stellants. I said this is the Stellant D. The D stands for dual because there's two syringes here. There's their newer version of this, the Stellant Flex, is this syringe right here. And you can see the obvious difference there, but then down here, and I know you guys probably from a distance, but where the syringe interfaces the injector head down inside the well, these are different here. Okay, so even on the Stellant, there's 2 different kinds of syringes. But yeah, for the most part, every single contrast injector model has syringes that are unique to it. And again, I mentioned this earlier, one-time use only. We use the syringe on one patient, throw it away. All right. There are some like, so for CT and MRI injectors, they are dual head injectors, meaning there's 2 syringes. One syringe has contrast, the other one has saline. For angio injectors, and this is always true, angio injectors, that's the ones in your CTs, cath labs, IRs, interventional radiology, they just have one syringe, just a contrast syringe. Angio, they don't use saline to flush out fluid or produce before and after pictures and things like that. So for CT and MRI injectors, 2 syringes, they're dual head syringes. For angio injectors, just single head syringes. Yep, I talked about that. And I mentioned the syringe heater down at the bottom, used to maintain the temperature of the contrast. Now, they also, so if I have 2 syringes here, I only have, if I have 2 syringes, the green side here, this is contrast, the blue side, blue is water, so this is the saline. Saline is basically salt water. So if I have a heater, again, the whole purpose of the heater is to keep the contrast, my syrupy contrast, at 37 degrees Celsius. So if we're doing a dual shot where we're going to fire some contrast in the patient and saline as well, we also have to keep the saline at 37 degrees Celsius. We can't have the saline at room temperature, because when we shoot them and they mix together, there's no point in having one nice and heated up and the other one's not heated up. This will cool this off. And then that just kind of kills the purpose of doing this. So if they use heaters, which they don't always, but if they use heaters, they'll have a heater on both sides as well. The saline doesn't need to be heated up for viscosity purposes, it just needs to be heated up so it doesn't cool the contrast off. Yep. It does, yep. You know, there's ports in the back for that. Yep. All right. Now, I mentioned these earlier, actually. So we talked about flow rate selection. Now, again, for CT and MRI injectors, maximum flow rate is 10 milliliters per second. Because CT and MRI procedure, everybody's had an X-ray, right? So when you have an actual X-ray, you know, you're on the table, you know, they'll have the start switch, the exposure switch in their hand. They'll be like, all right, hold your breath, beep. It's literally over in 100 milliseconds, and then you can breathe. All right. So for angio injectors, there's the injector system that goes for on your X-ray systems. Because the image capturing procedure is so fast, sometimes we need a massive quantity of contrast right here, right now. All right. So that's why angio injectors can go up to flow rates of 40 or 50 milliliters per second. Okay. Whereas CT and MRI procedures, anybody ever had an MRI procedure? Those are like 20 minutes minimum. It's at least 20 minutes, half hour, 40 minutes, something like that. It's a very slow procedure. So for MRI injectors, I never need 30 milliliters of contrast right here in 1 second. All right. It's always, we're just going to put an IV needle. We're just going to sort of slowly highlight the whole patient. All right. So we don't need high flow rates for MRI injections. All right. So maximum flow rates for MRI is 10 milliliters per second. They never shoot that. They never shoot 10 milliliters per second. It's always 2 or 3 milliliters per second in that range. CT, not as much as MRI, but CT is also a slower, longer procedure. So same exact reason. CT injections also only go up to 10 milliliters per second. So that's also why their pressure limits only go up to 300 PSI. Lower flow rates, lower pressures. So that was flow rate. I talked about volume selection, and then volume selection could be anywhere from 10 to 200. It could run the whole gamut. And then we spent time talking about the pressure limit, PSI, for pressure selection. Okay. Again, I wish I had. In the future, I just have to plan better for this. I need to have a little button down at the bottom that if this happens, I just have a little button down and I can click it and show the video of what I'm about to talk about. Only use it if I need it. Okay, so a multi-phase or a multi-level injection, all right? I really wish we had the display working. So think of it like a spreadsheet, all right, like an Excel spreadsheet, all right, rows and columns, all right. On the display here, your columns here. So the first column is flow rate. All right. Second column is volume. Third column, and then, well, that's it. That's it. The third column is time, but that's just calculated. So let's say I want to shoot an injection, a contrast injection, flow rate of 5, volume of 20 milliliters. All right. So that is a single phase injection. That's the whole injection. I'm going to shoot a flow rate of a volume of 20 milliliters at a flow rate of 5 milliliters per second into the patient. All right. That is a single phase injection. All right. But let's say I want to shoot some contrast. I'm going to follow that up real quick with some saline. All right. So now, that first row, which was my 5 milliliter per second flow rate, 20 milliliter volume of contrast. Now we're going to program a second row of a saline injection. And that's going to be a volume or flow rate of 2 milliliters per second and a volume of 10 milliliters, something like that. So that's a 2-phase injection. So the first phase, we're going to shoot contrast at 5 and 20. Second phase, we're going to shoot saline at a rate of 2 milliliters per second, volume of 10. That is a 2-phase injection. And then if I want to go back to contrast, then we can program a third phase, different flow rate, different volume. Then we can do a fourth phase. Some of these injectors, they'll go up to 6 to 8 phases. Okay, and I say multi-phase, multi-level. Every single injector on the planet refers to what I'm talking about as a phase, but there is one model that actually we mentioned, and it's end of life now. One model out there uses the term phase for some reason, and it's the Probus, which was until recently the most popular angio injector out there. So we had to talk about that term multi-level, but it's the exact same thing. That's a multi-phase injection. We're going to shoot some of this, followed by some of this, then we're going back to this at a different flow rate, back to this at a different flow rate and a volume. So that is a multi-phase injection. And most injections, the vast majority of injections are a multi-phase injection. Rarely does a patient get on the table and just shoot one phase and you're done. It's going to be contrast followed by saline, followed by contrast, followed by saline. All right. So just a phrase, a term you need to be familiar with. Okay, go back in your mind and that 2-phase injection. All right, so we have phase 1 contrast, phase 2 was saline. All right, let's say we want to have a little bit of a stop between the 2 phases. We shoot the contrast and then we're not going to follow that up immediately with the saline. We're going to have a little wait. All right, there's 2 kinds of waits. There's holds and there's pauses. Okay, and they sound like the same thing, but they're not. Now a hold, so phase 1 is contrast, and then phase 2 is a pause. What we're going to do first, a hold. Phase 2 is a hold. Then phase 3 is the saline. All right. Now a hold is a permanent stoppage of the injection. All right. So phase 1, we shoot some contrast. Contrast injection is done. Phase 1's done. The injector goes into a hold, and your lights here will start flashing, and it just stops injecting. Now, and these right here, this is the red button here is the abort button. And then the yellow button is actually the start and stop inject button. All right. And then my display down here has the same buttons, a red button for stop and a yellow button for start and pause. I didn't use that word pause. That'll confuse you. Temporarily stop the injection or stop the injection. All right. So we hit that hold phase. Now the system will stay in hold until the operator reinitializes the button and the system moves on to the third phase. Okay. That's a hold. Now a pause is the same exact thing, but instead of a permanent stoppage in the injection, if phase 2 was a pause, that is, we're going to program in a specific length of time. We're going to say 5 seconds. Pause for 5 seconds, then go into phase 3. So the difference between a hold and a hold is a hold, and then the injector doesn't start injecting it until the operator hits the button. A pause, the operator doesn't have to hit the button. A pause is a specific length of time, then the system will automatically move on to phase 3. Yeah.
So that's probably based on just the different procedures that
yes, absolutely.
It's just whatever you're trying to achieve. Fitting the image.
Yeah.
That's why there's the 2 different.
Yes, but here's the thing. I buy these contrast injectors all the time. Used contrast injectors because students are the worst. Hate students. No, they're students. They don't know things. Sometimes they break things. So, and it's no big deal. It's part of the, it is what it is. So I'm constantly having to buy used contrast injectors because things get broken. In transit, like here, this is broken. I can't fix that 15-volt power supply. I just have to replace it. So I have to I buy these things all the time. And whenever I get them, they always have they always have the protocols stored in memory. Those phases I was telling you about, like that protocol that I had, you know, phase 1, phase 2 hold, phase 3 saline, they'll name it something, you know, they'll call it pelvic something like that, and it's stored in memory. Whenever I buy a used one, they always have all the stored there's no patient information, but all the protocols are always stored in there. 0 times, I've been doing this since 2008. 0 times have I bought an injector and looked at the protocols and there was a pause programmed in. I've never seen it. Every injector has the capability of it, but it's never a pause. It's always a hold. And I think it's because it is hard. I mean, I'm not the expert on procedures for using contrast injectors, but it's got to be difficult to say, all right, and we need exactly 3 seconds before. I think it's always a hold, and then when they're ready, they're like, all right, no, let's move on. All right, things like that. I've never actually seen a pause permanently programmed into a protocol. All right. Delays. How am I doing on time? Oh, okay, doing good. There's 2 kinds of delays. They go by 3 different names, but there's really just the 2 kinds. All right. So we have our injector, and then we have the imaging system. Okay. Now the first kind of pause. All right. So I mean, and like I mentioned earlier, the injector, not CT, the injector and the imaging system, they're working in tandem with each other. All right. Now sometimes they want both systems to start at the same time. Hit both buttons and boom, they're both shooting at the same time. But that's not always the case. Sometimes I want one to start and then the other one to start so many seconds later. All right. So the first kind of delay that we're going to talk about is inject delay, and it's just exactly as it sounds. All right. The imaging system is going to start, and then so many seconds later, the injector starts. That's called inject delay. Okay. So and it can be anywhere from 1 to 99 seconds. So a typical delay, I honestly don't know. It can't be any more than a few seconds. But typically your delays or your injector delay is just going to be 2 to 3 seconds at the most. And that just basically gives the imaging system time to start getting the radiation going, and then we'll introduce it because they're going to be watching it live on the screen. So that's the easy one. All right, inject delay. Now the opposite of that is we're going to start this procedure, but the injector is going to start injecting first, and so many seconds later, the imaging system is going to start imaging. Now, for CT and MRI injectors, it's a CT scanner and an MRI scanner. So for CT and MRI systems, it's called scan delay. All right, but for angiographic procedures, that's an X-ray system. So it's not an X-ray scanner; it's an X-ray system. All right, so that is referred to as an X-ray delay. So 3 terms, but 2 meanings. All right. So inject delay is one, and then scan or X-ray delay is the other. I honestly don't know how often delays are actually used. I haven't really paid attention. I don't think very often. I think most of the time it's simultaneous. There's obviously times that it is used, but I think the vast majority of the time it's simultaneous. Any questions? All right. KBO. If you guys deal with infusion pumps, things like that, you're familiar with the term KBO. KBO stands for keep vein open. And this is for IV needles. So what will happen is, so this is CT and MRI only. Angio injectors don't have KBO capabilities because that's a catheter that's snaked into the patient, all right? But if we're using an IV needle, which is how they use CT and MRI injectors, what can happen is if we have the IV needle in the patient's arm for an extended period of time and no fluid is actually injected into the patient, a blood clot can form at the tip of the needle, okay? So keep that from happening. I mean, it's small, but to keep that from happening, what they'll do is they'll program in a KBO injection, keep vein open. And what that is when the patient is laying here and the injector is not injecting, there could be many minutes between injections or before we actually start the injection. What they'll do is they can program in a KBO. And what that is some injector models have a constant trickle, like 0.1 milliliter per second, just a very slow dribble of contrast coming out. It's typically, it would be saline. They don't use contrast for KBO. Saline, because saline is just salt water, it's cheap. Contrast fluid, whether it's CT or MRI, is very expensive fluid. So if we're going to use KBO, we'll use the cheap salt water. Some injectors, it's just a constant 0.1 milliliter per second trickle of it. Most injectors, however, they'll do just like a quarter of a milliliter drop, just every 15, 20, 30, 45 seconds, something like that. Just enough to keep the IV, the tip of the IV needle from allowing time for a blood clot to form. All right, so that's KVO. Again, CT and MRI only, angio injectors don't use it. Don't use it. Is this? Okay, I didn't think that was in. And then a test injection. Now, a test injection is just that. Oftentimes, like I think twice I've had to have contrast done because I'm getting older, and when you're older, they do more medical tests on you. You know, you go to the X-ray room, you lay it out on the table, and then they put the IV needle in you there at the X-ray table. It's not like you showed up from surgery or showed up from the emergency department with the IV needle already. Sometimes it happens, but most of the time they do it there in the room. Now, to make sure, I mean, let's say I'm going to shoot, 100 milliliters of contrast into the patient now. Before we go doing that, how about we make sure that we actually got the needle in the vein, all right? So what they'll do is they will program a test injection. Now, a test injection is obviously going to be a very slow, very small amount of fluid, low volume injection. And again, they'll use saline for it. They'll shoot the test injection with saline. It's literally going to be like 1 milliliter per second for 5 milliliters or something like that. So what they'll do is, because normally, so this is by the patient, is obviously attached to the patient, so it's in the room, it's right next to the table, the imaging table with the patient, and then the operator leaves the room and they go into the control room, and that's where my display is here, right? But before we do that, before I fire all this fluid in the patient while I'm in the other room, while I'm still standing here at the table with the patient, I'm going to do a test injection, all right? And so when I hit the start button, the test injection starts, all right? Now, so the operator is literally going to stand there by the patient's by the patient's side, watching the arm, making sure that it doesn't swell up. That means we miss the vein, and then it's called extravasation, where fluid just builds up underneath the skin versus going into the vein, okay? So your test injection is always going to be your first phase. Remember the phases we were talking about, multi-phase injections? Your test injection's got to be first phase, all right? There's no point in doing 3 phases of injections and go, hey, maybe we should see if we actually hit the vein, all right? So your test injection is always phase 1, and it's always followed by a pause. So whenever you do a test injection, they don't have to so what I mean is, phase 1 test injection, and then when the test injection's over, they don't have to hit the pause button and go back into the control room and finish off the rest of the injection. Whenever a test injection is programmed, the test injection automatically, once the test injection is complete, the system automatically pauses. Then the operator goes back into the control room, and from there, with the yellow button, they'll initiate the rest of the injection, okay? Simple enough, test injection. All right, the basic injector head components. So you can see in the picture here, it's the same exact injector head that we have here. My enable buttons, and I really wish this were working because this is a lot of demonstration stuff here. So these forward and reverse buttons right here, okay? These are they're variable speed forward and reverse buttons, and each one we can drive the piston forward and reverse at different rates using the forward and reverse buttons. So these buttons here are used to fill the syringe, okay? Now, yeah, I wish I could do this. This button right here, all right, the one in the middle, okay, that's called the enable button. Actually, on the newer Stellants, I know this must have been confusing some people because on the older Stellants, it was literally labeled enable. Yep, it was labeled enable. And then at some point in the making of Stellants, they changed the name to move piston. I think enable was confusing people. So before these forward and reverse buttons work, you have to hit the move piston button. You hit it, and you have about 5 seconds to start moving the piston up and down, all right? And it's a safety thing, obviously. If the patient's connected to the table, so the patient's connected to the injector, and we go to tilt it, and we hit one of these buttons, and all of a sudden we're shoving fluid in the patient before we're ready, it can cause problems. So that's why the move piston button has to be hit before these buttons are actually live and active. And after about once the piston stops moving, after about 5 seconds, the move piston button disables itself. Forward and reverse buttons, and then every injector except one, it's the ACES CVI. ACES CVI. I don't remember if I said this at the beginning of class, but I tell my students this all the time. You've seen one injector, you've seen them all. Yeah, I did go over that. I tell the students, You know, if you know how to work on one contrast and you know how to operate one contrast injector, you know how to operate all of them. There is one exception, and that was that company that I said that doesn't work and play well with others, Bracco. Again, great company. They make great injectors. They're not very friendly to you guys. And their angio injector is like no other injector on the planet. It's like, I can only imagine the meeting they had all the Bracco engineers in the room. They said, all right, who in here has never seen a contrast injector before? Has no idea what a contrast injector is. Anybody who raised their hand, they said, all right, go in the other room, just make up a contrast injector how you think it would be. And that's what they did. This contrast injector is like nothing. Doesn't have manual knobs. Doesn't have forward and reverse buttons. All right. If my syringe is here at 100 milliliters and I want to back it up a little bit, 5 milliliters, and move it forward 2 milliliters, too bad. Should have thought ahead. You have to shut the whole thing down, make it restart, take all the tubing off, and there's a lot of tubing. It's a great injector. It's just totally different. Totally different. It's just, that's why it's weird. So yeah. So enable button, forward reverse load buttons, and the manual knob. And the manual knobs do the same thing as the forward reverse buttons here. It's just, if I just want to move it, you know, just forward a couple milliliters, just get that last little squirt of air out of there or something like that. You can use the forward buttons. It's easy. Sometimes just easier to just spin the manual knob and get it out a little bit. The armed indicator light, it's a safety feature. So we're all hooked up to the patient. My syringes are filled with fluids. All right, we're going to do this injection. But before I hit this button, again, there's a safety feature here. If I hit this button, nothing's going to happen until I hit the enable button, or the arm button, not enable, the arm button. So when you hit the arm button, and you can arm, it's called arming the injector. Arming the injector means we're going to arm it, because now when we hit the start switch, we're going to go. You hit the arm button on the head, or you can hit the arm button on the display at either place. Once the system is armed and ready to inject, then the system will flash some sort of lights. All right, somewhere on the injector head will be flashing lights, and that is the visual indicator of the operator is like, all right, when you hit, we're going to fire now. You hit that button, we're going to shoot. It's just another safety feature. Did I hit this by accident? I did, yeah. So before the operator can be beginning the injection, they have to arm it. Okay, and every single injector, even the weird ASUS one, exact same thing. It's called arming the injector, and it won't shoot until the system is armed. Oh, that was it. No big flourish at the end, sort of. Bev, and that's it. That is all my students go through this. It's not this exact presentation. There's a little more to it for the students that come to my training. But yeah, all the students do this training online on our website. They take online quizzes before they show up for the first day of class. That way, everybody has this base knowledge. So when they show up in class to start the maintenance training, they're already kind of up to speed a little bit on the basics of contrast injectors. Anybody have any questions on it? I think I timed it out just, oh man, right on the button. Think how they actually would, if this were working, we'd be over time, because then I would take more time demonstrating stuff. So this is actually good. This wasn't working. Perfectly fine. Any questions on? Yeah. Oh, that really is model specific. So like this one, for instance, this is the Stellant. So this Stellant right here, this is, I don't remember if I mentioned it earlier, this is the Cadillac of contrast injectors. This is the most common contrast injector on the planet. Probably 90% of all CT injectors in the world is this model right here, the Stellant, now the Stellant Flex. So on the Stellant Flex, for instance, he asked, you know, what's the most common issues? For this one, this board right here, this is my display board, because contrast gets on it, this is the board that is physically pushed on, so it physically wears down. This is common for a lot of models. This is the head cable. Okay, obviously this is the head cable coming out of it. They called it the head cable. I don't know how they came up with that. And this goes, it's about 6 feet long, and it goes to an extension cable. And the extension cable here, this is what goes up in the ceiling or through the floor to the power supply down here. All right, and this could be anywhere from 25 to 100 feet long. It comes in 25, 50, 75, 100. But anyway, one thing I didn't talk about, whenever we fill the syringe, all right, whenever we're filling the syringe, we fill with the injector head pointing up, all right? Because when air bubbles or air gets in the syringe, we have to purge them out. When we get rid of it, we're going to inject, we always tilt the head down, all right? That way, if somehow it floats to the non, it's head down. And that's done many, many times during the day, every single day throughout the year. So this cable right here just gets a lot of flexing here over the years, all right? And what happens when you take a wire and you just do this to it over and over again? Eventually, it's just going to pop. So the head cable on the Stellant is another very common issue. And ironically, the power supply down here, there's two boards in there. There's a 15-volt power supply and a 48-volt power supply. The 15-volt power supply is never an issue unless it's used with these Certegra monitors. It's a whole other story. But the 15-volt power supply is almost never an issue. But the 48-volt power supply in the Stellant goes bad all the time. Okay, and that's just an example. Like for the Spectra Solaris MR injector, totally different issues. It's really very model specific. But in training, we do go over for all the different models. The last thing we do is we go over with the students the two to 4 or 5 most common issues that they'll run into in the field and go over those what those fixes are for them. Yep. Yes. Yep. A lot of things we only verify, but the real quick answer, like MedRad is the maker. Bayer MedRad is the maker of these. Bayer MedRad has their own software to do all those things. We can do everything Bayer MedRad can do. We just do it slightly differently. If things need calibration, they'll go in with their software, and they'll do all the calibrations of the pressures and the plunger positions and everything. They'll do it electronically, whereas we'll go in and we'll physically do it. We'll turn pots and things like that. Yeah, there's a couple exceptions, but yeah, for the most part, we can do everything the manufacturer can do. We just don't always do it the way they do it because they have their own proprietary software. No. To be honest, I've never heard of that. But I can't tell you. Do you know, is it for the Stellant that they're complaining about? Okay, so for the Stellant, when the system is in a certain state, there is an electronic brake that does make it. I mean, you can see here how easy that is to spin it. If this were actually turned on, this would not do that. You'd have to crank it, because when it's on, there is an electronic brake. You can turn it, but you really got to force it. It's designed to do that on purpose. So I don't know if they're like filling the syringe with the manual knob with it off, and then they notice that difference when it's on. Because to be honest, I mean, most of the time they rarely actually use the manual knob, rarely. So I'm thinking, if it's what you're describing, the system's designed to do it that way. So yeah, if you could call the manufacturer and they'd say, yeah, it's supposed to do that when the system's on. Is there somebody in here right after me? Okay, we'll be real quick. Because I actually had, without going into it, so this is the Stellant D, and there's a new Stellant Flex. Now, and the operators do this all the time. To fill the syringes, they'll put both syringes in like that. On the Stellant D, you can do that. On the Stellant Flex, you can't do that, all right? Because the Stellant Flex, without getting into it, there is a circuit board in here that sees when you put a syringe in. This one does too. The Stellant D has a circuit board that sees that as well. But for the Stellant D, you can do that, and the board doesn't care. It says, yep, I saw both of you. On the Stellant Flex, it's a different board. And the Stellant Flex, that board can't walk and chew gum at the same time. You have to do one, then the other. And it doesn't have to be like a 10 count. I mean, you can, boom, boom. That's fine. The Stellant Flex, okay, I saw that, all right. I had a student call up. Actually, I don't remember if he was a student, but he was a BMed. He knew what he was talking about. And he said that the department was complaining about that. They got a new Stellant Flex. And he said that when we put both syringes in the same time, it throws up an error. I'm like, yeah, it's going to do that. He said they've always done it that way. I was like, well, yeah, they have the old thing. No, they said they've always done it on the Stellant Flex. I'm like, what do? You're the BMed. You're like, well, you're wrong. It absolutely, you know what? Call Bayer MedRad. They'll tell you the exact same thing. I don't know what you thought you were doing in before, but I guarantee you on the Stellant Flex, you were not snapping them in both at the same time. Yeah, we were. All right, well, they changed it. You can't do that anymore. I don't know. I mean, what are you going to say? There we go. Any other questions?